Good afternoon, everybody. I'm Janet Hughes. I'm a reporter from Gloucestershire Live, and we're here today because we're in a collaboration with the NHS in Gloucestershire to share their vision for the future. They've already started this work with Fit for the Future 1, and now we're moving on to the next stage, Fit for the Future 2. And what that is going to do is look at 6 specialisms and how their ideas for the future for delivering these to you. And they're really important specialisms. Some of them are inpatient, some of them are outpatient, but they actually want a conversation with you to find out your views on their ideas and what you think about it. And that's why we're doing this today. We're going to be holding a series of Facebook Lives. There's going to be one daily for each specialism. And today we're talking about frailty. And yesterday we talked about respiratory and talked through with one of the consultants there about their plans and their vision and their ideas and suggestions on what they'd like to do with that. And now we're going to do the same today. And we're going to talk about it with overall the vision to have centres of excellence with the Director of Strategy and Transformation, who's Simon Lansley, and the person who's going to be in charge of delivering this, Dr. Sangeeta Kulkarni, who is in charge of frailty at the hospitals. So we're going to start with Simon today. Can you tell us a bit about your vision and the Centres for Excellence idea?
Yeah, sure, Janet. So this is the next phase of our clinical strategy. So viewers may remember we had a conversation in 2020 where we set out a number of changes under phase 1. And the strategy remains the same. So this is still about focusing more on the provision of emergency care at Gloucestershire Royal Hospital and more on planned care and oncology at Cheltenham General. Important to note, this is not a purist model. So we're not saying all emergency care happens at one site and all planned care happens at the other, but where it's where our clinical teams tell us it's better for patient outcomes, access and experience to centralise a service on one site, then that's what this one programme is all about. And the idea of centres of excellence, we're not saying that all 30 of our clinical specialties will become centres of excellence in their own right, but it's about, particularly around the emergency care, it's about co-locating those services on a single site. So when they work together, they can rapidly triage, diagnose and treat a patient because they're all on the same site. They often use the same teams, the same equipment. So the centres of excellence for emergency care is about the co-location of services that work together. And then over on the planned care site, it's services that often plan their treatment in advance. So people will have a date to come into surgery. And the evidence shows that if you co-locate those services on the same site, then you have more reliable access to diagnostics, to beds, to theatres. So you can avoid those patients being cancelled. So strategy is the same, Janet, as we talked about in phase 1. There's just is the next phase of it. So another 6 specialties that we're looking to fit into that strategy.
And as I understand it, phase 1 has been completed, and the elephant in the room was Cheltenham General. And I understand that you have a strategy for Cheltenham General, which involves keeping A&E on that site.
Yeah, so really clear to be, I suppose it needs to be clear what's not in scope of phase 2. So the same as phase 1. So Cheltenham Accident Emergency Department remains as is. So it will continue to be a consultant-led unit from 8 a.m. to 8 p.m. And a specialist nurse-led unit overnight. And that model's been in place since 2013, and we're not touching that. Also, the reconfigurations we talked about in phase 1, there, as you say, most of those are implemented. 5 of the 7 are implemented, and the remaining 2 will come online in September 2023. So they're out of scope as well.
And just for the public, so that they know, phase 2 involves benign, non-cancerous gynecology, diabetes and endocrinology, frailty, non-interventional cardiology, respiratory and stroke. And most of these are inpatients, but also with frailty, it involves community services, which involve a lot of other professionals. Can you tell me why you want to involve the public in an engagement exercise, Simon, and how you plan to do that?
Yeah, so it's we found the feedback we received in phase 1 was really helpful. So actually it informed some of our decisions, particularly around the timing, and it was interesting to find out what was important to people. and we're aware that that's 2 years ago, and a lot's gone on in those last 2 years. So we wanted to come back out again. I think, again, just to remind people, the strategy stays the same, but here's the next phase of the programme and the specialties in scope, but particularly users of the service. So people that may have some of these long-term conditions, so diabetes, for example, or frailty, or have had a relative experience the stroke service. So we want to hear what's good, what's working well for you at the moment, what could we do better at? And it means we can then pick out those key themes and consider those in some of these ideas that we're suggesting. And as I say, we found that really beneficial in phase 1, so we wanted to do the same here.
And I understand it that basically this engagement exercise is going to go on from May the 17th to June, the end of June, but there will be conversations after that, and that'll a series of public meetings. Am I right?
Yeah, that's right. Yeah, so there's quite a lot going on. So in addition to these Facebook sessions that you mentioned, we have our information bus that is travelling around the county. So today it's in Cirencester and it goes to Stow tomorrow. And we'll do a few references, I think, to the website getinvolved.glos.nhs.uk. If viewers go on there, you can see all the bus site visits that we're doing, these Facebook Live sessions. And then from the 5th of July, for each of the 6 specialties that you mentioned, we have an engagement workshop which people can join either face-to-face, or actually what we found in phase 1 is we often get better attendance when we ran them online. So we're offering a dual offer there. But yeah, each of those 6 specialty areas, people can come and join and be part of that to again share their views.
Okay, yeah. And we're going to talk to Sangeeta now. Can you tell me a bit about your role and what you do at the Hospital Trust?
Of course, Janet, thank you. So as you mentioned in your introduction, I'm a geriatrician. My specialist interest is in looking after older people. I'm predominantly based at Gloucester Hospital. Bulk of my work involves looking after patients who actually attend the hospital in what we call as an emergency. So either via the emergency department, or if they've fallen and broken their hips. So the main subspecialism is called as a frailty, which I'm sure most people have heard about. What it means from a medical perspective is the functional ability of a person to be able to bounce back from an illness. So just to give you an example, someone who's not frail would be able to recover from a minor illness within, say, 24 hours to 48 hours without much of a remnant, if you like. However, a frail person would present in a slightly unusual manner. They'll take longer to recover, and they would probably need a lot more care. And that's what we specialize in trying to preempt the frailty, spot it, manage it, and then hand the person back to where they came from.
And there's a lot of people in the community who are doing this, as well as in the hospitals, aren't there, with physiotherapists and dietitians. Do you work closely with them?
That's absolutely correct. One can get a very skewed picture when you focus on hospital, but frailty is all around us. And it's not black and white. There are grades of frailty, starts from 1 to 9. And there has been a lot of work within One Gloucestershire around frailty. For example, when you visit your GP practice, you might come across frailty matrons who work alongside GPs and pharmacists. There's a lot of work within the Gloucestershire County Council to try and keep people active within the community. We've got false assessment and education services to try and address false risks and to try and correct these. And at the other end, at the sharp end, there are multiple other teams, such as the complex care teams and the rapid response teams, who could jump in and address an acute illness to try and prevent a hospital admission. So from a hospital perspective, where we are placed, we reach out to all these other areas at a more strategic level. We link in with these under the banner of One Gloucestershire, and we have regular meetings to try and come up with a single vision for the county.
And you've come up with a bit of a vision for your area at the moment, haven't you? Can you explain how you see it going forward in the future?
Of course. So the demographics within Gloucestershire is changing, and we feel that we would be able to adapt it to the Fit for the Future model. So the current situation within Gloucestershire hospitals, there are 3 care of the elderly wards at Gloucester, with a combined bed numbers of 93, whereas in Cheltenham, we've got 1 care of the elderly ward with 32 beds. Our intention is to try and balance this across both the sites, with the intention of moving 1 ward from Gloucester to Cheltenham. So that's within the inpatient base. We're also trying to redesign how we assess frailty at the front door. So within Gloucester hospitals, the current system is if a frail older person becomes unwell, comes into Gloucester hospital, they have to go through several stages before we can actually assess them as a part of our frailty unit. So they would go from the GP to the paramedics to the emergency department and then finally be assessed by the frailty unit. In our future model, we would like to see these patients directly in our frailty unit. So we are in the process of creating a direct admissions pathway where we are directly communicating with the paramedics in order to minimize the amount of time that a frail older person stays in the hospital, do a comprehensive geriatric assessment, so look at the whole person rather than a solitary illness, and put in measures, communicate with the wider community team, and try and place the person back within the community. So those are the changes within Gloucester. We are hoping to redesign our existing wards with the intention of having a short stay model for patients to remain there for less than 24 hours, and then 2 further wards for up to 72 hours and slightly longer. At Cheltenham,
Sorry, I understand that Gloucestershire has people who are admitted to the hospital in Gloucestershire. One of the reasons for this is that because they have to go through quite a lot of systems before they meet you, where people are staying in hospital a lot longer than the national average. And this will mean, am I right in saying GPs will be able to eventually refer directly to yourself? And people will get the help they need straight away rather than having to go through various stages.
That's absolutely correct, Janet. So we're already partly working along those lines, but in the future direct admissions model, we are hoping to build on our synapses model. So synapses is a way in which a GP can directly ring a specialist in older care or older person's care and try and work out whether there are any ways where we could avoid a hospital admission or arrange for them to be sent to the hospital, bypass the long waits for ambulances within the emergency department, do an assessment as promptly as we can. So yes, it's direct conversations with GP is part of the future model.
And it's not about saving beds. You're going to actually extend the beds in Cheltenham. It's about people who are staying in hospital actually having a poorer outcome.
That's correct. So as I mentioned earlier, the idea is to do a whole person assessment, and we call that as a comprehensive geriatric assessment. And within that, it's not just about their medical problems, that we try and incorporate their social, mental health, their medications, their mobility. So we have a huge team of specialists who work with us. So in the future model, alongside movement of 1 ward to Cheltenham, we're also thinking about opening up a same-day emergency care model geared towards patients who don't really need a hospital admission. However, they need to benefit from assessment from this huge specialist team that we have. And if you try and concentrate on their presence at the front door and get that assessment done at the right time by the right person, we would be able to avoid a hospital admission.
Yeah, and it's not good for patients to be in hospital as they're older because they deteriorate, I understand, a lot of the time. But I'm quite intrigued as well about part of the plan is for, what do they call it, a virtual ward. Can you tell me a bit about that?
So the virtual ward model, it's something that actually gained momentum during the pandemic, where we have tested our technological ways of assessing patients. And it's also ways to communicate with the wider team that is currently there within the community. So virtual ward model is to try and have an oversight of the frailest frail within the community who have a high risk of getting admitted to the hospital, whereas they would want to spend the majority of their time at home. But we would bring in the specialist skills that are present within the hospital to the patient via the community partners, such as the frailty matrons, GPs, etc. So we've got consultants within the department who have specialist interest within community geriatrics. So that's part of the future model.
So in short, can you tell me the benefits of this?
So we all recognize that patients don't want to spend their time in the hospital. They would much rather spend their time at home. They don't really wish to be in a situation where part of the problems have been over-medicalized. So the benefits really are to reverse frailty where it can be reversed, to spot frailty at the earliest possible opportunity, and avoid a hospital admission where it's appropriate to avoid a hospital admission, because we are not here to try and avoid a hospital admission at all costs. We recognize that there are some patients who will need to come into the hospital, and when that need arises, we are there, we are prepared with all the right resources. Okay.
And are there any drawbacks?
The drawbacks are really the planning and the strategy that goes behind it will need some time. It needs a lot of resources. We'll have to balance some of the resources that are currently existing, and it will take time. I can see more benefits, and as you mentioned earlier, part of the benefit is really to reduce the amount of time that people spend in the hospital, whereas they would much rather be at home.
So you think it's more beneficial for the patients?
It's definitely more beneficial for the patients to be under the care of the right professional at the right time, whereas when they come into the hospital, because there is a finite number of beds, the chances are they get admitted under a different specialty, under a specialist who are not really geared towards looking after frail older patients. So the advantages are really to try and get these numbers right so that we can preserve the beds for the appropriate care of the patients.
Thank you. I think you've explained that really well. So thank you for explaining what your suggestions and ideas are. Can I come back to Simon, really? We've got how the public have been involved. You've explained to them. Who do you want to get involved in this consultation?
So, so as I said, people that are users of these services, so particularly across the 6, so diabetes, frailty, non-interventional cardiology, stroke, or benign gynecology and respiratory. So either the users of the services themselves, or perhaps have a family member or someone they're responsible for the care of that's had an experience. So we're particularly interested in hearing from those people. And people that perhaps haven't usually engaged in these sorts of things and thought, actually, that's not for me, particularly those. So on the website, there's a range of ways you can get involved. On the back of the booklet, there's different languages. There's a free phone number people can call to get a different version of the booklet, an easy read version, as I say, or in different languages. So particularly interested in those members of our society as well.
And it's a very important area for people to get involved in, isn't it? Because it impacts in the community, and it also has an impact on how the hospital is run, really, because if people are coming through the front door through A&E, when they don't need to be, they could be going straight to the frailty unit. Surely that'll have an impact on A&E waiting times.
Yeah, it can do. Yeah, exactly. And as Sangeeta said, and it's part of the wider strategy, it's getting people to the right specialist first time. So you asked the question about disadvantages. It doesn't necessarily apply to frailty because we're looking to provide the service on both sites, but where you see us moving services between sites, often the some of the feedback we get is, particularly if we move a service from Gloucestershire Royal to Cheltenham General, people in the west of the county say, well, now I've got to travel further to access that service. And there is an element of that, and we need to be open and honest. There is an element of that. People have to travel further, but actually you travel further and you see the right team first time, and they've got the right equipment around them, and they've got reliable accesses to the resources they need, then the patient outcome is better, because we get that care at the right time first time.
Yeah, and we've had some questions from the members of the public that I'm hoping you can address. We've got one from Sheila Dring here, who says the Centre of Excellence model has been used successfully in other disciplines, so it's not blue sky thinking. The only reason this might fail is if the funding is not available. Is there funding required going to be new funding, or just diverted from other areas?
Yeah, so we get asked that. I think it's important to state up front, this is not a program driven around financial savings. This is around improving quality and safety. And when you improve quality, you often do reduce cost. But I think we understand there'll be some areas that we need to invest, but it's not necessarily all new investment. So if you pick a service, say, that's currently provided on both sites, we're struggling with some workforce and recruitment areas at the moment, which means that we can be reliant on agency staff, which comes at a premium. Or where we've got services on two sites, we're having to maintain kit and equipment on both sites. So where you're able to centralize those services onto one site, you get better use of the colleagues. So you can, a service that was Monday to Friday, 9 to 5 can now be 7 days a week, because you've got all that team on one site. And we can make sure the investment we need on equipment, we're making it once, because it's on a single site. So there will be some funding we'll need to do, but I don't think it will be 100% of everything. There'll be some benefits in there as well.
And one of the things, in terms of COVID, has this driven any of the changes that we're seeing now in frailty? It certainly has in respiratory.
Yeah, Sangeeta, I'm not sure if there's anything direct from COVID. I think what was interesting in COVID, and particularly in the scope of phase 2 services, some of these changes were implemented as temporary changes. So the respiratory one you spoke about yesterday was implemented in response to COVID, and actually the learning there was so good that we think that could become a potential permanent change, which is the idea we want to talk about. And again, in stroke, we moved stroke services to Cheltenham General, and I think you're talking about that later in the week. Again, a change we implemented under COVID, but it's been some good benefits there. So we think there's benefit for that to become longer term. In frailty, Sangeeta, you mentioned the virtual ward, which is something you've adopted. Can you think of, is there anything else around that we learned in COVID?
I think we've always recognised the need for the patient to remain out of the hospital unless there's a good clinical indication. However, there have always been certain situations where we didn't really recognise that it was possible to manage a certain situation at home. What COVID has done is that's actually given us the confidence to be able to deliver that remote monitoring. And it's actually given us the confidence to be able to communicate with teams remotely. So I think it's empowered us to utilise these resources. So in that way, I think COVID has done us a favour.
Can you reassure people? Because I'm sure there's some people out there who will be thinking, when you talk about remote virtual wards and things like this, about technology and frailty and elderly people, how they all fit together. Has it worked well over COVID? Has it shown you that it works?
So I would like to assure that the underpinning principles for frailty management is something called as a comprehensive geriatric assessment. So it all starts with basic, solid medical assessment so that we all understand what is the question we are trying to address, rather than keeping someone out of the hospital simply for the sake of it. There has to be a clinical question that has been answered, and for the virtual model to provide the resources to deliver that solution. It's just as important to make sure that we are offering the right amount of medical input. And it's important to use the word right, because it can be too much of a good thing. Over medicalization is a known entity, and that's what we are there for, really, to try and strike that very fine balance.
Okay. And Simon, I think it is open answer. What happens next?
Yeah, sure. So we've got another 4 of these sessions. So encourage people to listen to hear from other colleagues around some of the ideas. I mentioned the bus tour, so you can the ticker tape along the bottom, that getinvolved.glos.nhs.uk. If viewers can go and see there, you can see hopefully there's a bus coming to you soon that you can meet some other colleagues and hear more about it. And then the engagement workshops we talked about in July on that website, opportunity for people to come and take part in the discussion, broader discussion, perhaps getting some of the detail, and great for us to hear from people, because we're in listening mode at the moment. So the more people that get involved, the better for us.
Okay, thank you. Well, I think we've come to the end. I don't think there's any more questions coming in at the moment. But this is the second of a series of Facebook Lives, which will be discussing the changes that the suggested changes and ideas that people are coming up with to go forward into the future at our hospitals. So I'd just like to say thank you very much, Simon and Sangeeta, for explaining all that to us, and goodbye to everybody, and tune in tomorrow for another discussion. Thank you.
Thank you.